The bacteria uses PABA with pyridine to make dihydrofolate using the enzyme synthase, and then it converts the dihydrofolate to tetrahydrofolate using the enzyme reductase, and then uses the tetrahydrofolate to make the bacterial DNA. Now we can block either the synthase or the reductase by folate inhibitors. So folate inhibitor antibiotics blocks either the synthase or the reductase enzyme to block the synthesis with the bacterial DNA, and this results in the bacterial death. Sulfonamide and Dapsone are synthase inhibitors, while trimethoprim, pyrimethamine, and methotrexate are reductase inhibitors. Now we can use either of these classes to block the DNA synthesis, or we can use both classes to have sequential blocking of the DNA. Dapsone can be used to treat leprosy or pneumocystitis jirovecii. Now, Dapsone has three main side effects that you have to know. First, it causes agranulocytosis with methemoglobinemia, and in patients with G6PD deficiency, it can cause hemolysis. Resistance to Dapsone can develop from the folate P1 gene mutation. It's a point mutation in the P1 gene. Sulfonamide is a very common antibiotic, and it can be used to treat many gram-positive and gram-negative infections, both serious and mild. And most importantly, it can treat nocardia. Nocardia presents very much like TB. It actually presents like a lung nodule with symptoms of hemoptysis and chronic cough with mild fever. So just like TB, except that TB has PPD positive test, while nocardia has PPD negative test. Sulfonamide, just like other folate synthesis inhibitors, cannot be taken in patients with G6PD deficiency because it will cause hemolysis. Now, sulfonamide interestingly displaces albumin-bound drugs. There are certain drugs that once we take them, like warfarin for example, the blood thinner, it will go into the circulation and will bind to albumin and be circulating with albumin. This will decrease the bioavailability of the drug. Now, once this patient takes sulfonamide will displace warfarin or whatever other drug is bound to albumin and make it freely floating. This will increase the bioavailability of that drug drastically. So we will have more effective warfarin, as if the patient is taking a larger dose of warfarin or whatever other drug is bound to albumin. Sulfonamide also causes the double S, so serum sickness-like reaction, which is a hypersensitivity type 3 reaction, and there are only certain medications that can cause this. So if you remember them and you see serum sickness-like reaction in the exam, it has to be one of those few medications. Sulfonamide is one of them. And it also causes the other S, which is Stevens-Johnson syndrome, the skin reaction with descaling. Resistance to sulfonamide can develop by increasing PABA and pyridine, so the blocked enzyme by sulfonamide will have more substrate to work with, or by the bacterial efflux and influx, so the bacteria will have more drug efflux, which means once the drug enters the bacterial cell, the bacteria will use the plasmid to efflux the drug, to get the drug out of the cell before it works in the cell, or by decreasing the influx, which means decreasing the intake of the drug into the bacteria. Trimethoprim has more potent and serious side effects, so we tend to use it less in the clinical practice. It's mainly used for gram-negative infections, like Salmonella and Shigella, and sometimes pneumocystitis jirovecii. Now, trimethoprim treats marrow poorly, TMP, so it causes bone marrow suppression and megaloblastic anemia. Megaloblastic anemia part is very important for exams. All folate synthesis inhibitors can cause megaloblastic anemia, but trimethoprim is the most one that is likely to cause megaloblastic anemia. Trimethoprim works by inhibiting the reductase enzyme, and the bacterial resistance develops by upregulation the production of the reductase enzyme. So we'll have far more enzymes than antibiotic.